Hi everyone. So I would like to live stream pathology. So okay, so we see. Now let's say that oh, what's happening here? Give me a second now. Okay, so oxygen to be effective necrosis, cases necrosis, fat necrosis, traumatic fat necrosis, fibrinoid necrosis, liver, so on and so forth. Now, so we read this one, liver again. So, okay, you hear me well? So do you hear me well, right? Okay. Now talk about liver triad area, portal vein, hepatic artery, bile duct. Liver is unique because it has a dual blood supply, and so hepatic artery and portal vein will dump blood into sinusoids. So others assemble of sinusoid organs are bone marrow and spleen. Characteristic of sinusoids: gaps between endothelial cells with nothing there so things can fit through. Things like red blood cells are inflammatory cells. Bone marrow is penetrated. Have little tiny pores within the cells for filtration. Sinusoids have a gaps so large cells can get through them, not through with the GBM because it is intact, and little pores allow filtration. Portal vein blood and hepatic artery go through sinusoids and eventually taken up by central vein, which becomes the hepatic vein. The hepatic vein dumps into the inferior vena cava, which goes to the right side of the heart. Therefore, there is a communication between right heart and liver. So right heart failure, blood feels behind fail heart. Therefore, the liver becomes congested with the blood, leading to nutmeg liver, also known as congestive hepatomegaly. If you block the portal vein, so nothing happens to the liver because it is before the liver. So blockage of hepatic vein leads to artery and liver become congested. Which part of liver is the most susceptible to injury normally? Around central vein. Because it gets first depends on oxygen coming out of the sinusoid. Zone 1. Zone 2 is where yellow fever will hit. Mid-zone necrosis due to HEP. Zone 3, which is around portal vein, which will have less oxygen. It's analogous to renal medulla, which only receives 10% of the blood supply, and the cortex receives 90%. Fatty chain is around zone 3, part around central vein. So, therefore, when asking about acetaminophen toxicity, which part is most susceptible, which is around central vein, because it gets the least amount of oxygen and therefore cannot combat free radical injury. Alcohol-related liver damage, most common cause, fatty chain alcohol. So this is a metabolism of alcohol, NADH and acetylcholine. Acetate is a fatty acid, and acetylcholine can be converted to fatty acid in the cytosol. NADH is a part of metabolism of alcohol, therefore for biochemical reactions. So what causes pyruvate to form lactate in anaerobic glycolysis? NADH drove it in that direction. Therefore, always see lactic acidosis, a form of metabolic acidosis in alcoholics, because the increased NADH drives it in that direction. Also, in fasting stage, alcoholic will have trouble making glucose by gluconeogenesis because they need pyruvate to start it off. However, you have a lactate and not pyruvate. Therefore, alcoholics will have a fasting hypoglycemia. Acetylcholine can also make ketone bodies. So acetylcholine, SMG-choline, and beta hydroxybutyric acid, C beta hydroxybutyric ketone bodies in alcoholics because it's an NADH driven reaction. Therefore, two types of metabolic acidosis seen in alcoholics are lactic acidosis, because they drive in pyruvate into lactate and increase synthesis of ketone bodies because excess acetylcholine. So main keto acid, beta hydroxybutyric acid. Why does it produce fatty change in glycolysis? Around reaction 4, get intermediate dihydroxyacetone phosphate. So NADH reaction and is forced to become glycerol 3-phosphate. Guillain-Barré question. The glycerol 3-phosphate shuttle get ATP, also important to carbohydrate backbone for making triglycerides. Add 3 fatty acid to glycerol 3-phosphate and you get triglycerides. In liver, the lipid fraction, FVLDL, endogenous triglyceride is synthesized in liver from glycerol 3-phosphate derived from glycolysis. Restricting fat will not decrease the synthesis of VLDL. Restricting carbs will decrease the VLDL synthesis because its glucose intermediate it is made from. Glycerol 3-phosphate is a product of glycolysis, which is why fatty liver is most commonly due to alcoholism. This reaction. Inflammation 1. Kwashiorkor. So that we read before already. Now, hemosiderin and ferritin, we also read that already. Huh? Now, talk about types of calcification, dystrophic and metastatic. Dystrophic calcification means abnormal calcification. The damaged tissue gets calcified. Example, seen in enzymatic fat necrosis, chalky white areas on X-ray are the result of dystrophic calcification. For example, football player with hematoma in foot becomes calcified dystrophically. Calcium binds and co-produce dystrophic calcium deposits. Serum calcium is normal, but damaged tissue becomes calcified, occurs in atheromatous plaques, causes serious tissue damage, therefore they are difficult to dissolve. Need to be on the honest diet, a vegan diet. Most common cause aortic stenosis. Most common cause congenital bicuspid aortic valve. Dystrophic calcification also leads to a hemolytic anemia. Slide aorta has only two valves doing the job of three, and gas damage leading to dystrophic calcification, so which narrow orifice of valve leading to aortic stenosis bicuspid. No? Now, metastatic calcification in cases of hypercalcemia or hyperphosphatemia. So calcium is actually made to deposit in normal tissues, non-damaged tissues. Most common cause hypercalcemia outside of hospital, primary hyperparathyroidism. Most common cause hypercalcemia inside the hospital, that's a malignancy-induced hypercalcemia. With hypercalcemia can put calcium in normal tissue. This is called metastatic calcification. In dystrophic calcification, there is damaged tissue with normal serum calcium level. In metastatic calcification is when there is high calcium or phosphorus serum level. Actually, when calcium is deposited into bone, it is the phosphorus part of the solubility product that drives calcium into bone. High phosphate level, very dangerous, will take calcium and drive it into normal tissue. This is why have to put the patient with renal failure on dialysis cause a very high phosphorus serum level, therefore needs to dialyze the phosphate because the phosphate will drive calcium into the normal tissue. For example, in the heart conduction system, renal tubules, basement membranes, so nephrocalcinosis only to damage. Okay, now cell membrane defect. Red blood cell membrane defect, so spherocytosis is a defect in spectrin within red blood cell membrane. If you can't see the central area of pallor, if you don't see the donut, then this is spherocyte. Okay, spheroid, just like a ball, like a balloon type. Absence of spectrin with the within the red blood cell does not allow the red blood cell to form. So because we know this biconcave, right, like a donut, red blood cell mature like that. But if we did not see that, they call this spherocytosis because what defect in spectrin, remember in membrane. So absent of spectrin with the red blood cell does not allow red blood cell to form a biconcave disc. It is defective and therefore form the spherocytosis. Okay. Now ubiquitin. Ubiquitin, which is stress protein, high ubiquitin levels associated with high levels of stress. Some of the intermediate filaments, keratin, desmin, vimentin, are part of superstructure of our cells, frame of the cells, upon which things are built. When these intermediate filaments get damaged, the ubiquitin must then fall destruction. The intermediate filaments have been tagged ubiquitinated and marked for destruction. Some of these products have names, for example, there are open spaces within the liver tissue. These spaces are fat and they are probably due to alcohol. The ubiquitinated products of the liver are called Mallory bodies. These are the result of ubiquitinated filaments called keratin, and these are seen in alcoholic hepatitis. Another example, silver stain of neurofibrillary tangles, Jacob, Creutzfeldt, and Alzheimer's disease. Tau protein is related with neutrophil tangles. This is example of an ubiquitinated neurofilament. Example: substantia nigra in Parkinson's disease include inclusion called Lewy bodies. Neurotransmitter deficiency is dopamine. Lewy bodies are ubiquitinated neurofilaments. Therefore, Lewy bodies, and neurofilament tangles are only samples of ubiquitination. Now talk about cell cycles. Are very important. So big time. Different types of cell. Labile cell where the division is via the stem cell. Three tissues that have stem cells, bone marrow, basement membranes of skin, and the base of crypts in the intestine. So, uh, three tissues that have a stem cells, the bone marrow, the basement membrane of skin, and base of crypts of intestine. Oh, what time now? Okay, 1 hour. Okay, right. Okay. Now, uh, anyway, so we have a stem cell, huh? Stem cell, which is in bone marrow, basement membrane of the skin, and the crypts in the intestine, base of crypts in intestine. So these cells have a tendency to be in the cell cycle a lot in form. So pharmacology, there are cell cycle specific and cell cycle non-specific drugs. The cells that are most affected by these drugs are the labile cells because they are in the cell cycle. Complication of these drugs are bone marrow suppression, diarrhea, mucositis, and rashes in the skin. There are stem cells in all these tissues. Stable cells in resting phase, T0 phase. Most parenchymal organs, liver, spleen, and kidney, and smooth muscle are stable cells. Stable cells can undergo division, but most of the time they are resting and something must stimulate them to get into the cell cycle and divide, resemble a hormone or a growth factor. For example, estrogen in women will help in the proliferative phase of the menstrual cycle. So the endometrial cells are initially in the T0 phase, and then the estrogen stimulated the cells to go into the cell cycle. Therefore, they can divide, but they have to be invited by the hormone and a growth factor. Now talk about permanent cells can no longer get into the cell cycle and have been permanently differentiated. The other types of muscle cells, like a striated, cardiac, or neuronal cells, that's a permanent cells. Striated muscle, cardiac muscle, and neuronal cells. Only muscle that is not a permanent tissue, because smooth muscle. So hyperplasia, which is stand for what? Hyperplasia, which is increase in number. Hypertrophy, which is increase the size. Now keep in mind that. Would a permanent cell be able to under hyperplasia? Hyperplasia increase the number. Increase the number. The sense no. The reason permanent, which is no longer get into the cell cycle, right? They cannot generate the new cells. Because permanent cells, so they cannot go under hyperplasia. The answer is no. That gives common sense. Because that means small copies of it. Can it go under hypertrophy? The answer is yes. So if like that, we say if the heart, we always say the hypertrophy. Okay, we cannot say hyperplasia. Keep in mind that, huh? Our hypertrophy or dilated because hyperplasia, which increase number of cells. But if for prostate gland, they can say the hyperplasia. Okay. So now a smooth muscle can go under hyperplasia. The smooth muscle then okay, but the striated muscle no, cardiac muscle no, neuronal cells no. Keep in mind that. That's other types of muscles, permanent, like permanent. They call permanent cell, which is striated, cardiac, and neuronal. So they are permanent cells, so they uh, cannot increase the number of the cell, cannot hyperplasia. So that's why no for them. But hypertrophy, yes, yes, yes. So how about the smooth muscle? Smooth muscle, then the answer yes. Smooth muscle, so then they can increase the number and also increase the size. Like that. Now different phases of cell cycle. G1 phase, the most variable phase of cell cycle is the G1 phase. Compared with menstrual cycle, the most variable phase is a proliferative phase, not the secretory phase, and our proliferative phase varies with stress. However, once ovulation has occurred, it is 14 days. Therefore, proliferative phase is analogous to G1 phase of the cell cycle because it can be shorter or lengthened. None of the other phases, SG2 and M phase changes, they stay the same. Therefore, in cancer cells, once in the longer cell cycle will have a longer G1 phase. Cancer cells with shortened cell cycle will have a shortened G1 phase. G1 phase is the mastermind of everything. Cyclin dependent kinase phosphorylation and activation. Phosphorylation usually involves sending a message to activate something. Glucagon is a phosphorylator, while insulin is a dephosphorylator. So glucagon will phosphorylate protein kinase and activate it, while insulin would dephosphorylate protein kinase and inactivate it. So technically, glucagon increase, which is the causes insulin, which is a reduced glucose. Glucagon, which increase the glucose. So if the glucagons increase the glucose, which they activate the enzyme kinase phosphorylate protein kinase, also known as phosphorylator. But insulin, which is the lower glucose level in the bloodstream, so then they dephosphorylator or dephosphorylate protein kinase. Now G1 to G1 to S phase inactivates cyclin D dependent kinase. Cyclin D activates it, and G1 phase makes cyclin D. Once the cyclin D is made in the G1 phase, it then activates the enzyme cyclin D kinase. So therefore, it is now active. Key area to control in cell cycle transition from G1 to S phase, because if you have a mutation and it goes into S phase, it then becomes duplicated, then you have a potential for cancer. To suppress genes that control the transition, which is RB suppressor gene. Ribosome located on chromosome 13, which makes the ribosome protein, which prevents the cell from going from the G1 to the S phase. It's a board question. So in general, to go from S1 to G1 to S, the active silin deep kinase phosphorylates the ribosome protein. So when it is phosphorylated, activated, it can go from the G1 phase to the S phase. A problem occurs if there is a mutation. Therefore, the enzyme is checked by p53 suppressor gene located on chromosome 13, which makes a protein product that inhibits the cyclin D deep kinase. Therefore, it cannot go into the S phase. P53 is the number one most important gene regulates the human cancer. Example, HPV inactivate the ribosome suppressor gene and P53 suppressor gene. HPV makes the two genes products, E6 which knocks off the P53 and E7 which knocks off the ribosome suppressor gene. If you have a point mutation, the ribosome suppressor gene is knocked off. There will be no ribosome protein, and the cell will progress to the S phase because it's uncontrolled. This mutation in the RB suppressor genes predisposing to many cancers, such as retinoblastoma, osteogenic sarcoma, such as kids with the pain around knees, Goldman's triangle, sunburst appearance on X-ray, and the breast cancer. Ribosome suppressor can be involved depending on the age bracket it has in different areas. If you knock off p53 suppressor gene, the kinase will be always active. It will always phosphorylate the ribosome protein, and that means that it will always go into the S phase, and this is bad. If you knock off any of those genes, the cell will go into the S phase. The p53 suppressor gene is a guardian of the genome. So because it gives the cell time to detect if there is any defects, abnormalities in the DNA, splicing defects, codon thing, whatever, DNA repair enzyme can splice out the abnormalities, correct it, and the cell is ready to go to the S phase. If the cell has too much damaged DNA, then it's removed by apoptosis. Therefore, this gene is important because it gives the cell an opportunity to clean its DNA before going to the S phase. So S phase, synthesis phase, where everything is double, include DNA and chromosome from 2n to 4n. For example, if it's in muscle, it will have double the number of contractile elements. So T2 phase, where tubulin is made, important to microtubule of mitotic spindle. It is blocked by etoposide and pleomycin. M phase mitosis, where the cell divides into two end cells. The cell can either go into the T0 resting phase or can continue dividing into the cycle and can be permanently differentiated. P53 gene makes a protein to inhibit the kinase, therefore prevent the ribosome protein from being phosphorylated, therefore stays in the G1 phase. Therefore, when you knock it off, no one is inactivating the kinase, and the cell is constantly phosphorylated, and that keeps the cell dividing and then has potential to lead to cancer. Okay, now talk about drugs that act on the cell cycle. Drugs acting on S phase, so ergo alkaloids works on the mitotic spindle in S phase. Methotrexate was in S phase, so ergo alkaloids methotrexate the S phase. Example: patient with rheumatoid arthritis has a macrocytic anemia. Drug responsible for this is in what phase of the cell cycle? S phase, because it is methotrexate blocking dihydrofolate reductase. Now, two drugs acting on G2 phase, like etoposide and bleomycin. Drug in M phase, cryptophorin, M phase, so palitasol specifically works in the M phase. Clinical scenario: this drug is a chemotherapy agent made from the U3 cell paclitaxel phase. So when crysting and replasting, so this drug used to use treatment acute gouty arthritis, but because of all the side effects, it no longer used. So what drugs and where does it act? Which is colchicine phase. Colchicine is for acute phase, acute gout. Allopurinol, which is chronic gout. So they act in M phase. Clinical scenario that does not work on the cell cycle. HIV positive person with smear and white out the lung on the drug, so ends up with the cyanosis. So which drug? It's a dapsone. Okay. Okay, maybe we just stop right there. Anyway, thank you very much. So I can talk more next time. Thank you. See you next time.